Hello, everyone. Welcome to this RSM webinar on emerging from the pandemic, the future health service challenges. My name is Andrew Jack from the Financial Times, and today we've got three leading health figures to engage with you: Jennifer Dixon from the Health Foundation, Chris Ham from the King's Fund, and Nigel Edwards from the Nuffield Trust. Later during the day, I'm going to introduce a series of conversation points to begin, and we'd very much encourage you to use the question and answer form here on the chat to pose your questions to our three panelists over the next 40 minutes or so. But Nigel, let's turn first of all to you and talk a little bit about your experiences, as it were, on the front line, what you're seeing and what the big challenges will be in the coming weeks.
Thanks. I've been talking to a number of chief executives and chief operating officers, medical directors from hospitals particularly, but also looking at community services. And it's rather difficult situation will continue to operate because of the need for very extensive infection prevention and control measures. So, for example, even before the crisis, most accident and emergency departments were running way above the numbers of patients that they were designed for. In one case, I found nearly 100% more patients were turning up. Now, clearly, as patients start to come back because they've been avoiding hospitals, it's going to be impossible to provide any form of social distancing in the emergency department. So, within them, they'll need to be completely reconfigured, probably have to borrow space from other bits of the hospital. And every patient who comes to hospital will have to be treated as though they are potentially an infection risk. So lots of PPE and lots of sorts of friction with staff having to keep patients apart, to change. And you see similar things in the community, and the net effect of all of this and the testing required before planned or elective treatment is to slow the pace of which the NHS has traditionally treated patients, and maybe by as much as 30–35%, and in some cases more. And of course, over the period of the lockdown, we've lost a lot of headway. Every month, about 1.6–1.7 million people start a new course of treatment. And although referrals are down, that demand will come back. And during that lockdown period, probably only 20 or 30% of that work has managed to be done in many places. So we're looking at a big backlog, but also much slower productivity, and not just in hospital services, but also in healthcare and in primary care, beg your pardon, in general practice, and in particular in aerosol generating activities like dentistry, which is going to have a real struggle.
So Chris, does that resonate with you when we think about restoring services? How are things going to evolve?
So what I'm seeing in my work, I'm chairing the Coventry and Warwickshire Health and Care Partnership, and also on the board as a non-executive of the Royal Free, is there's a huge effort now going into restoring some of the really urgent services that were put on the back burner when COVID-19 emerged. I'm talking particularly about cancer services, cardiac services, other urgent medical conditions that really can't wait and need to be diagnosed and treated as quickly as possible. And the NHS is making use of the private hospitals that are being requisitioned by NHS England for the treatment of NHS patients, and that's certainly making a difference in my area. But I'd agree, I think the full restoration of services, particularly around more routine, planned and elective care and diagnosis of patients' conditions, will be impacted by COVID-19. It's difficult to say by how much. I've heard estimates varying from perhaps 50% of previously routine work can be restored relatively quickly to up to 75 or even 90%. I think, frankly, at the moment, we don't know, but Nigel's quite correctly highlighted some of the constraints in doing that. The other point I'd make is we shouldn't underestimate the impact that COVID-19 has had on the NHS staff. It's placed huge demands on them. They've risen to the challenge amazingly well and helped the NHS and patients get through that surge we saw, particularly in the middle of April. But there will be, and there are consequences that follow on from that, and that will impact on their ability now to restart the work. And we should also acknowledge there'll be a long-term effect around health and well-being of staff, which in itself will place demands on the NHS.
Jennifer, what are you seeing?
Yes, I mean, I'm clearly, Nigel and Chris have put that case very well of, the backlog and the productivity dip that will have to take place because the system can't be running at the same speed as it used to. So those are very significant issues, along with all the segregation and the practical things that the system will have to do to separate out COVID and non-COVID. But just a couple of extra points. I mean, I think the first thing is if there are, is to consider the demand side. So that is patients who maybe have illnesses or conditions where going to hospital is discretionary, and they are frightened of going still because of COVID, particularly older patients. That there is an issue there in terms of challenge of significant numbers of older people requiring care in the community in a way that we haven't seen before, particularly if these can't be helped by social care, because there are remaining constraints on social care, particularly due to funding, due to lack of reform. So I think there could be a bit of a perfect storm there, not least when lockdown ends and the carers, informal carers, get back to work perhaps. So that's one sort of thing. And the other thing is another element here is that quite a lot of health is supported by the charitable and voluntary sector. And there's going to be quite a lot of wreckage in that area where people who are providing services in that sector may not be able to work and provide services to the same extent. So in certain parts of the country, for certain groups of people, there will be vulnerabilities there. And of course, the NHS is a place where the lights are always on, and that kind of demand will have to be dealt with and mopped up and managed. So those are sort of some of the challenges, but also I'm sure we will get onto some of the opportunities that we've got. And the pandemic has taught us a huge amount about how to speed up decision making and to automate some things that previously weren't, for example, at all sorts of levels. And I think there's real opportunity for learning in our reset as we go forwards as to how that best some of that new decision making and speed can be bedded in and kept, which we're going to need, aren't we? Because we need to up productivity if the public finances are so shot through.
So Nigel, Chris had mentioned this issue of the backlog. What's your sense about how long it'll take and how the system will cope with trying to tackle both the parallel challenges of the ongoing COVID burden and this backlog elective surgery and other things that have been put now onto a long waiting list for many patients?
Well, I think it's likely that the deal with the private sector is going to need to continue. I guess there will be some opposition to that because people who are waiting a long time may well wish to pay themselves. Across Europe, this is an issue. People are starting to think about what criteria do you need to use and how do you approach this big backlog and indeed what will probably be a growing number of people waiting. One will be, I suspect hospitals will need to pool their waiting lists across whole areas, and the clinicians will need to think really carefully about what the criteria are for who is going to be treated first, and probably need to start thinking about some fairly objective criteria to do that. For some people, there may be some investigate alternative non-surgical options where that is a possibility, but there's a limited number of conditions where that's possible. And I think then there's probably some fairly hard choices about patients who are down the lower end of that priority list about what we say to them about when they're likely to be treated. It's a big concern.
And Chris, you talked earlier about these issues of that you're observing on the front line, as it were. I mean, how, from your own experience of the trusts you're dealing with, how are they responding or how will they plan for the next few months in terms of adapting to this huge backlog?
Well, one way in which they're responding is taking the learning from the response to COVID-19, where increasingly what I observed was that local hospitals came together to plan for the surge that we saw and to use their intensive care capacity, particularly in a much more collaborative way, putting in place mutual aid. So, for example, if one local hospital found itself running out of intensive care facilities, the others would rally around and there'd be that mutual support to make sure that patients got treated, even if it wasn't necessarily at their local hospital. that must continue, because the future can't be independent fiefdoms around particular local hospitals or specialist centres. The NHS and patients will be far better served if we accentuate even more the work that started to develop these integrated care systems based on a county or a large city, and a commitment to work together to pool resources in the way that Nigel was alluding to. I understand there is a lot of interest in taking this further within NHS England and NHS Improvement, and the plans for reset and recovery beyond the current restoration phase will be system plans setting out how all the services, primary care, secondary care, mental health, links to local government, will come together to deal with that backlog, to do more of the work outside hospital where that's appropriate. And particularly, sort of one of the other take-home points is to really focus on prevention, tackling the health inequalities that have become much more transparent in response to COVID-19, and using resources to improve population health and well-being, very much in partnership with local government. I think that's what we're going to see.
The challenge, of course, has been the reduced funding, hasn't it, and removal of power in many ways from local authorities. I mean, Jennifer, what do you think about Chris's point about expanding the whole prevention side of things and movement outside the health service to the wider different institutions and communities?
Well, I mean, I've been in public health since, 1990, I think. And since then, everyone has been talking about rebalancing the health service and investing far more in prevention. And, we haven't seen masses of progress. In fact, we may have seen the system going backwards, particularly with the public health infrastructure, I have to say. But I do think this pandemic is changing views, isn't it? And I think it's really shone a spotlight on the population health stock and what it takes to protect the population health stock. This is coming through time and again from the polling that we've been doing, which has shown that the public are clamouring for protection and investment in health. So I think in addition to the kinds of things that Chris is saying about integration and agencies locally working together, which, by the way, does require investment in local authorities and public health infrastructure, as well as probably the charitable and voluntary sector. I think there also needs to be much more of a strategy for the national things that can be done to improve health. And there we talk about action on the risk factors that, for example, make environments obesogenic or contributing to mental health issues. So those things, as well as a much bigger focus on the role of local government and the wider determinants of health, particularly where they're, as we have seen, really impacted on certain vulnerable groups, not least ethnic minority and Black and ethnic minority groups. So I'm hoping that this has helped to create not a temporary, but more of a permanent reset in views and attitudes about prevention and support of vulnerable people that might filter through to political decision making and therefore investment decisions. We'll see in the autumn whether or not that really is translating into it. But I think the case, as Rishi Sunak stood on the steps of I think it was number 10 and one of these briefings, and saying, there isn't a trade-off between health and the economy. The two go hand in hand. Let's see if that sticks.
Nigel, we were talking earlier about social care, of course, this other fundamental pillar that we've seen the big weaknesses during COVID. Again, do you see any sort of chance of a momentum for a different form of partnership between the NHS and care providers that will help pave the way for a sort of better future?
I think there's various things we've seen revealed. The first more generally, actually, is that as a country, we are probably interested in community service rehabilitate us up quickly, allowed hospitals, unfortunately, in a few cases, it seems that there was a knock-on into care homes, which is really, really unfortunate. But what this revealed was that, as well as a very major funding problem, which governments have ducked for the last 20 years, we've also got a very significant problem in a fragile market with problems with staffing, with low pay and relatively poor management. And I'm not entirely confident that we're going to see that being fixed.
Chris, do you want to come back on that, on social care?
Yes, so I think what's happened is that the under-resourcing and the second-class status of social care, particularly in care homes, has been made much more visible. A lot of us have been talking about this within our foundations for as long as I can remember, and many reports have been produced highlighting the funding gaps, the workforce challenges, and the issues around quality of care, both in domiciliary care and in care homes. It's there now in plain sight for us all to see. It's going to be hard for governments to continue to kick this down the track and ignore the pressing needs that exist. So for me, one of the big opportunities around reset and recovery is to challenge the politicians, all of them across the spectrum, to really now do something. We've had endless reports, we've got numerous recommendations, we know what the issues are. What we absolutely don't have is any political will to do some of the necessary things, both in fixing the existing system, because there are the immediate financial and workforce challenges, but more importantly, working towards a new settlement for social care and health together, to create a sustainable basis for the future, and then taking some tough decisions about how to raise the necessary funding. There will be implications for taxation, for national insurance, difficult issues that politicians have shied away from, but now hopefully is the moment where we can make some progress.
And just a sense on that, but what is your current perspective on really what should be done, therefore, in the integration of care?
I mean, I think there's been some interest in going back to Andrew Dilnut's report, which would be a step forward. But Andrew himself would, I think, be the first to admit it's not a comprehensive solution. It's a way of capping people's exposure to social care costs. The King's Fund did work with Kate Barker about 6 years ago now, setting out an alternative blueprint for the future based on the idea of a new health and social care settlement, based on bringing entitlements to social care into line with entitlements to the NHS, but doing so over a 10-year period, because you couldn't do this quickly, and thinking through what should then be the model of social care delivery. Are we over-relying on care homes, residential care? Could we do a lot more to support people to remain independent in their own homes? And what does that imply around the housing options available to people in later life? So, in 3 sentences, that's a huge agenda for the next decade.
Yeah, and Jennifer, Chris touched there to some degree on the issues that you've raised before around inequalities, both for patients and for staff in the NHS. What more do you think there really needs to be done? Do we know what needs to be done, in fact?
Well, the big message is, how this virus has impacted on the most vulnerable groups. And actually, it's exacerbated the inequalities that were already there and that were laid out by Michael Marmot, for example, in the Marmot Review 10 Years On that we published in February, and we're very pleased to support and fund. There's a whole agenda there that Michael set out, which relates to reversing some of the aspects of austerity which need to be tackled. But this is much bigger government agenda. And the question is, have they got a headspace really over the next few years, given the economy, to deal with it? If you look at Angus Dayton and Anne Case's book, Deaths of Despair, that came out looking at the inequalities in the United States, they didn't lay the finger at the door of austerity, because probably in the US there is permanent austerity in terms of public sector spending and welfare spending. But what they did point the finger at was long-term structural changes in the economy, which have crushed communities in the US, which, the decline of industrialization. Many have written about this. And the question is, if we reset welfare state, if we reset social care, just as Chris is saying, which I completely agree with, where is the thinking to reset some of the economy that can affect the wider determinants of health that are underpinning some of the health problems that we're seeing that create these enormous health gaps? And that's an enormous agenda. I mean, given strict back government, do they have the time, agenda, headspace to reset in that way? I don't know, but many people are thinking about it. But unless we can get at some of the fundamental wider determinants, a bit more for public health is not going to cut it when it comes to addressing these vulnerabilities. And last point is, some of these inequalities in health are completely and utterly avoidable. If we want a flourishing economy, we need a better health, don't we? So So that's the agenda, and it has to be a whole government strategy.
Okay, so let's open it up now to some questions amongst viewers. And the top of the list here, so is focusing on where we are now and thinking about the next few weeks and months. Do you think there'll be a second wave? And if so, how will this impact on the NHS? And will the Nightingales be able to step up to support it? Chris, do you want to come in on that first?
Yeah, so I think the immediate prospect is not of a second wave like the first wave. The immediate prospect is there'll be local flare-ups, local outbreaks in small communities, because all the evidence we've got in front of us around infection rates and so on is moving in a very positive direction. We're not out of the woods yet. And I think, as Jonathan Van Tam said, we are at a dangerous moment with the lockdown being eased ahead of having a fully functioning test and tracing system in place. And I'm really worried that there are still a lot to do to develop a so-called world-class or world-beating test and trace system. We are nowhere near having that yet, although a lot of work is taking place to move us closer to that. So I think in the foreseeable future, over the summer months, local flare-ups and outbreaks, this is where the public health directors in local government are now working incredibly hard on their local outbreak plans, the local contact tracing, working with Public Health England, and hopefully integrated with the national contact tracing system that the government put a lot of faith in, wrongly in my view, in the early days of developing the current test and trace approach. But beyond that, as we look into the autumn and winter, a lot of the public health experts are saying it is likely that some countries will experience a second wave. We're not quite sure how high that will be, what sort of peak it will reach, or indeed whether it will match the sort of pressure the NHS faced in March and April this year. But anybody who is prudent in their planning would absolutely have that at the heart of their thinking, and making sure, therefore, that the NHS has the capacity in intensive care, in hospitals and care homes, are now properly prepared in a way that clearly was not the case for the first wave to deal with a growing demand. I hope we don't get into that position, but if we do, then there are some very clear lessons we need to learn quickly from what didn't go well first time round.
And Nigel, will we need much more real-time and localized information on infection rates for hospitals and social care and so on to respond meaningfully if there is a second wave?
Quite a lot of infrastructure to do that has now seems to have been put in place. The whole story of this pandemic appears to be being several weeks behind the curve on where we should be, particularly compared with some other countries. I agree with Chris that the whole approach to testing and tracing has not been a good story, and it's still not very clear that we're going to have that in place. But more has been done to create data and analytics to give real-time information about where capacity is and how to use it best. I think the question, one of the questions on the feed also mentions the Nightingales in response to this. I mean, one of the issues that's highlighted is the fact that, as both Jennifer and Chris has mentioned, the NHS is short of staff, was 40,000 nurse vacancies short going into this crisis, and to some extent has been hoping to be able to fill some of that gap with international recruitment. Well, I'm not sure about this, but I suspect we're not the most attractive international destination for health professionals now, after some of what's been seen about our performance in the management of the pandemic in other countries.
So Jennifer, yes, again, for you, I mean, how ready are we for a potential second wave? And maybe linking up to one of the other questions here, do you think the NHS and parts of it that have been suspended will be able to meaningfully return in the meantime?
Well, I agree with both Nigel and Chris, the NHS has learned a lot in the last few months. It may not be able to magic up more capacity quickly in the way that it has done for Nightingales. There's a fixed bed capacity, and also there's a fixed staff capacity. And the second wave is a very real risk, as indeed other winter pressures that are coming forwards. Coupled with that, on the other hand, the demand side is quite important, because meaning the public demand for care, everyone's, I think, been surprised at the precipitous drop-off of demand for non-COVID care. That, according to our polls, as I say, is due to a fear of actually turning up at a healthcare facility and getting infected. So there's going to have to be a lot of work done, I think, to try and assuage fears amongst the public on that. And as I think they see the NHS getting itself organised more on that and separating out COVID and non-COVID, I think that hopefully will be allayed. On the other hand, there has been, as I say, rapid learning as to what works and what doesn't. And surely, we've got a lot of capital coming from that. Chris mentioned how people have been working across localities and geographies to try and make things work. But there's also been fantastic horizontal learning across clinical specialties. So how safely to do this or that in the case of a COVID patient, for example, has been done rapidly through horizontal learning. And there's also been horizontal learning amongst managers as well, with respect to shifts in care and services as opposed to individual treatment. So we've got quite a lot to learn from. We are not an outlier in that respect in facing the same kind of risks as other countries, except perhaps our test and trace is so much weaker and is only just now getting up to speed.
So a very practical question, very popular. Chris, perhaps you want to go deal with this. So do the panel think we're stuck with PPE for life?
Well, who knows? I mean, there's so many uncertainties, aren't there? I hope not, but we should make precautions, at least plan for the foreseeable future, both for the care home sector and for the NHS. And of course, not forgetting the need for PPE in the community, whether we're talking about domiciliary care workers and dentists who are now back at work, primary care and so on. Maybe here there's opportunity to help to regenerate our own economy by relying less on the big Chinese suppliers. Obviously, we struggled to source the necessary equipment from them during the peak of the pandemic, and having more of our own homegrown resources.
Nigel, and perhaps touching also on what you've observed in other health systems elsewhere in response, I mean, how more generally, whether it's PPE or working practices, do you think will be kind of in a new paradigm, really, in a post-COVID era, in part driven by concerns about a return of infection and how to control it?
Yes, indeed. On PPE, there was a real issue, which is quite a lot of staff work nursing staff work 12-hour shifts. Well, working 12 hours in full PPE is not an attractive prospect, so there'll need to be some change there. Perhaps the most notable change that Jennifer and others and Chris have alluded to is the shift to new ways of delivering care, and in particular, the abandonment of face-to-face consultation. Large numbers of general practice consultations and quite a lot of outpatients are now happening on the phone. Video, which lots of people have been excited about, proves only to be useful in a relatively small number of cases, and actually you can look at photographs and do virtual clinics on the basis of information. So I think people were experimenting with that, so lots of innovation of that going on in the last few years. It's really accelerated. There are limits to it, however. I think there's a degree of techno-optimism here that you still do need at some point to lay hands on a patient. There were physical examinations to do, and in mental health and some other disciplines, actually be able to see people is something that's quite an important part of the interaction. So I think the shift to technology, which may also enable more self-care. I came across a very interesting example of a community provider that had taught patients who had leg ulcers or needed other forms of wound care to do self-care, and were rather embarrassingly getting better results in terms of wound healing than they had with their own specialist staff. And they were using video to teach the patients how to do it and provide supervision. So lots of opportunities here to use the technology in new ways. But to be honest, quite a lot of it will be a workaround, and it won't offset the general productivity loss that we were referring to earlier, I fear.
Thanks. Jennifer, maybe we'll come to you next. There's a question here about what the panel thinks about the re-establishment of locally based public health services. So with a medical public health consultant and team attached to each city council or county.
So the question is what we think about this.
Yes, would you say that is desirable?
Yeah, well, I think the move to public health in local authorities is a step forward, and which was done way back in, was it 2012? Because so much of health is rooted in communities in which people live, and as I was saying, the wider determinants. I think there obviously have been real questions raised about how the local public health infrastructure works with the national and indeed the private infrastructure with respect to test and trace. And that still isn't clear exactly how the national is working with the local, whether it's tier 1, 2 or 3. So I think there are questions there about how this works, as well as probably the capacity and capability and investment in public health, whether it's communicable disease control or whether it's to do with wider health and public health issues that we really need to address. I mean, I personally left clinical medicine and started in public health in 1991. And at that point, there was a big Acheson review of the state of public health in England and where to go next. And it was a kind of renaissance of public health and to try to put it on a much more solid footing. And I think we probably need another review of that at some point to strengthen and to be able to prepare ourselves for future risks, short-term risks like COVID and other insults that are short-term, disease-based, communicable disease, but also longer-term, slow-burn insults that might arise out of slower changes, like the long-run effect of mental health issues increasing in younger people, the longer-run effects of obesity, and indeed wider issues like climate change. So I really do think this is the time to have a relook and a reboot of public health.
Chris, apart from funding, are there any other things that could be done to try to revitalise the public health system?
First of all, to recognise it's already there and to value it and to support it. I think one of the major mistakes the government has made in its response to COVID-19 is trying to do too much centrally, using the levers that ministers have their hands on through the Department of Health and Social Care or Public Health England, and only late in the day recognising the council's expertise, public health directors, their teams, but going beyond that into environmental health and trading standards. And all of these people have expertise absolutely central to locally gathering intelligence and responding to local outbreaks and then taking the necessary action. I was delighted to see Tom Reardon, Chief Executive of Leeds Council, working in the National Test and Trace team, giving evidence to the House of Commons Communities Committee yesterday, really being very articulate in saying what we need is not a centralized approach or a localized approach. We need central local government partnership. And then within that, we need partnership between local government, the NHS and the voluntary and community sectors. So we're using all of our assets. And I hope if the government is learning anything at all through the approaches taken, it can't do everything. If you try and centralize, you will not get it right. You need to trust people locally, give them the resources, give them the permission to do what only they can do in their areas. And the public health teams must be at the heart of that.
So let's move on. We've talked already a little bit about this. We've got a question here about private medical hospitals. So what's going to happen with the current arrangements? Will it be steadily run down over time? Nigel, do you want to come in first?
Well, I think they will want to return to treating private patients. The NHS, it's reported today, is wanted to try and hang on to that capacity at least into to the end of the financial year, which is March of next year. I have to say, some of these private hospitals are run by charities, and it does make me slightly wonder whether they can really claim to hang on to their charitable status if they're going to perhaps take a step away from the sort of the social solidarity that we will be needing to deal with the crisis that we now face, in favour of treating privately insured patients, and whether or not we actually, just because of the situation we're in, we need to take much more of a community approach to how people are prioritised rather than their ability to pay. The purely commercial private sector is a different matter, but those private hospitals run in the charitable sector, I think, should really take a hard look at themselves and ask if they want to hang on to their charitable status, how they ought to be behaving.
Jennifer, how do you see the balance with the private hospitals evolving in the next few months?
Well, firstly, I must apologise. Somebody's decided to cut down a tree outside my house, and I can hear too. So if it's too, I may have to shout. So apologies for well, I don't know what more to add really, except that the private provision is here to stay. Private provision is a useful adjunct for the NHS, particularly if the NHS itself is not planning the capacity that it needs. You know, I think in recent years, in the last decade, the private sector has relied more and more on income from the NHS and working to NHS prices. So I don't see that changing anytime soon, nor do I see, given the current economic climate, a massive expansion in private hospitals or charitable hospitals for that matter, because the money simply won't be there to support them. And as we know, the amount of health insurance or people's ability to pay will totally depend on the economy rather than the performance of the National Health Service. So it's a useful but always a marginal extra amount of supply. A supply of beds and also facilities and staff. So I can't see the landscape changing anytime soon, with the exception of the economy having a dampening effect on the profits of those groups.
So we've got a couple of questions about particular subgroups with access to health services, those with disabilities and how to engage with them correctly, and a concern that perhaps children, because they didn't seem to be so affected, is there a risk they'll be deprioritised or overlooked? Chris, do you want to comment on that?
I think there's more recognition now as we approach this this phase of the pandemic, that there are important groups in the population, people with disabilities, including children with disabilities, and the impact of the lockdown on them and their family members, and not being able to go out from their homes and often living in rather cramped accommodation. And that's added to the pressure families were already under. But children more generally, I know that paediatricians have been speaking out about this in recent weeks, their concern that the reduction in referrals, reduction in treatment that they're experiencing, and the concern legitimately about the need that is building up in the community, that at some point will have demonstrably adverse effects on the health of children and families. So all of these issues are now in the mix. We've spoken originally about the elective surgery restarting urgent acute work, but I wouldn't underestimate at all the issues that have been raised by these questions.
So we're moving towards the end, but I wanted to get in a sort of forward-looking question here. So we're going to expect more pandemics in the years ahead. In what ways specifically can we ensure we're better prepared for the next one, and also to cope with simultaneously those affected by future pandemics and those with other regular health conditions? Nigel.
Well, I suppose we could not abolish the government committee that's responsible for planning for pandemics 6 months before one. Probably is one step that would certainly have helped. Spare capacity is an issue in the NHS. It's been one for years. The Treasury view has always been that spare capacity equals waste. And if there's one thing that the pandemic has really illustrated, is that the very, very fragile, long supply chains, lots of outsourcing, running everything at 98% capacity means that you have no ability to respond, and indeed your systems may well collapse under the weight of even quite moderate increases in demand. And to some extent we see that in microcosm every winter. So I think one thing that we probably need to do is what other countries have done better than us, is to keep more spare capacity. And as we start to think about building the 40 new hospitals, or bits of hospitals that were promised at the election, perhaps one lesson here is not to strip out all the spare space, make the corridors as narrow as possible, and leave very small spaces between beds in shared areas. There's a very large number of lessons about how we think about and plan health services. I think the second lesson Chris and Jennifer both alluded to is that actually central command and control works very well for some things, but turns out to actually be pretty disastrous, particularly if the people doing that central command and control aren't in particular in control, or that the system is so big, which is the case in our country, that it's difficult for them to be able to sustain that, and the development of much more trust in local government and local organisations to sort things out and retain national command and control for those areas where it's important, for example, to stop people competing on the procurement of goods and services, or for things that only can be done at national level. So there's a whole range of things, and hopefully there will be some sort of inquiry into this that will tease out those lessons. But let's hope it's quicker than most public inquiries, less expensive perhaps as well, and perhaps more action orientated than some we've seen in the past.
Chris, we're almost out of time, but anything you would add to that to prepare better for future pandemics?
Yeah, just one point. Much of our discussion has been about the supply side of health and social care. Let me just focus for a second on the demand side. One of the big take-homes from the response has been the contribution that we've all made, people, communities, to combating COVID-19, whether it's social distancing, hand washing, isolating where that's the right thing to do. And we wouldn't have made so much progress in recent weeks without people and communities being much more engaged. It was Derek Wanless in 2002 who said there needed to be a fully engaged community working with the supply side in health and social care to be able to sustain health services for the future. I think that's been reinforced by our recent experience. So let's build on that going forward and make sure we're well prepared next time around by using all of our assets and recognising the contribution that every citizen, every family, every community makes.
Jennifer, a final word?
Yes, thank you. I think my main takeaway is the need to build in capacity for planning and longer term view of longer term planning. We're so short-termers and we stumble from things to things. And I think to have the imagination, to have the planning, and that means people thinking about and imagining the future, whether it's a pandemic or whether it's some other major insult. We just don't have that. It's been stripped back, hasn't it, over the last 10, 15 years. So I think that's one thing. And also I think what this has also confirmed is the need for competent, what I would call technocratic competence in the system. And you just simply cannot stumble from decision to decision. There needs to be a competent technocratic infrastructure to be able to handle this level of complexity, as well as what Nigel was saying, that it can't all be done centrally either. So that takes patient building, and we need the thinking time and investment to do that.
Well, thank you very much. I'm afraid we've run out of time. There's a very good final comment or question here, thanking already our speakers and suggesting perhaps the RSM should coordinate with the Health Foundation, the King's Fund, the Nuffield Trust in trying to distill the sorts of wisdom that you've been coming out with today and put it directly to government. So I leave that as a challenge. But Jennifer, Chris and Nigel, thanks very much. And thanks all of you for watching. Goodbye.
Thank you.